Thank you very much. Thank you for inviting me to talk to you about genetics in atypical HUS. So do you always do genetics for your suspected atypical HUS cases here? Yeah, okay, all right then. So maybe I won't be able to teach you anything, but I will try. So just for the trainees in the room, the clinical characteristics of HUS or atypical HUS are microangiopathic hemolytic anemia, thrombocytopenia and renal failure. We know the condition can manifest in neonates right through to adults. We know that genetic causes we think are present in 60%, but not every study can pick those ones up. They frequently, if they have a genetic cause, they frequently experience relapse, as we've seen, and 60% of those with genetic diseases progress to end-stage kidney failure. So the genes involved in regulating the risk to HUS are those that are involved in regulating the complement system. And if you just paid attention to what I said that they pose a risk to developing HUS. In the conditions I talked about earlier this morning, monogenic conditions, there was no risk. They were always going to develop the condition. With atypical HUS, it's a really complicated disease where you can carry the genetic variant. We know that there might be incomplete penetrance, so some of them may not show themselves, but there's some sort of element of second hit. You need, in most cases, there's a trigger to showing the phenotype, to manifesting it, so whether that's pregnancy, transplant, cancer, viral infections, which is really common in children, or drugs. Eculizumab is a human C5 monoclonal antibody. It's only effective in the atypical HUS that's caused by complement-mediated genes. I'll show you a paper in a moment that shows that eculizumab, while it may preserve kidney function, it poses a 550-fold risk increase of meningococcal sepsis, despite you giving the vaccination and despite you giving the prophylaxis. And what we don't know is that how long should we keep them on eculizumab? It's such a costly medication, but also now we know that the neurological risks and the risks to hearing and the other systemic features. So the mode of inheritance is also typically autosomal dominant, with CFH being one of the commonest variants that you see, but you can also have autosomal recessive in non-complement mediated disease, in DGKE, and other rarer polygenic causes of atypical HUS. In the UK, earlier Dr. Mordy showed you Panel App, and he showed all these genes that were in traffic light colours. It's a nice app to have on your phone because it gives you quickly, you can see which ones have got a strong evidence base and utility, so that they will make a difference to the patient. Like Satish said, you were mentioning, was it the CFHR1 and CFHR4, for example, is not even on this thing because it's for such a mild phenotype that it doesn't warrant testing. So in the UK, we only test, we do a gene panel, now it's targeted exome sequencing, and we only report these ones. If there's any question about the phenotype, the lab will take data on these two genes, and they will tell you if you ask for it, but they won't give it to you otherwise. And these genes, even though there are papers suggested of a typical sort of causative role, they don't look at those, and they won't report them, and they won't give you the results. It's just interesting, isn't it? And so it's always good to check what you're going to get results for, so you can be prepared for unexpected things. So indications for testing, you guys will know. So if there's family history, so more than one member of the same family or first-degree relatives with atypical HUS, they have to be 6 months apart, and you have to make sure they haven't got a step organism. If there's an individual where there's been a relapse of HUS, even after complete recovery, then you can test. And if there's other environmental triggers, like I told you about, that look like they triggered the HUS, but we haven't found a step for it. So actually, Rajiv asked me just to look at the utility of testing. And so here we want to look at whether the genetic result will influence how we decide to treat them, and does it give us any information about patient outcome? So I'm sorry, I'm not covering the diagnostics fully here, but I'll explain why in a minute. So atypical HUS patients are all managed. Like I said earlier, I'm spoilt with all the Bardet-Biedl patients and the oxalosis patients. I look after them for the UK. But the team that look after the HUS patients are Newcastle. So if you have a patient that's got STEC, so they've got HUS, but you found a STEC organism, you don't need to discuss it with anybody. You can manage the patient in your centre. If you can't identify STEC, and they've got other triggers like viral triggers or drugs or whatever, then you have to discuss it with them because they get to keep the eculizumab. So in the UK, you're allowed to have 1 or 2 vials of eculizumab in your emergency drawer on your ward. So you could give that, and that's fine. But if you wanted more eculizumab, you have to ask them, and so they hold all the information. So they started sort of putting this into play around 2015 kind of time. And this is a really nice paper that you all have on your WhatsApp. You can look at it in more detail because you won't be able to see the details here. So they looked at their cohort of patients and they did whole exome sequencing plus copy number variant analysis to see which one of those patients, if they gave them eculizumab, how did they respond to the eculizumab? And of those rarer variants or non-complement mediated disease, what was the outcome? What was their prognosis over time? So they had roughly 2,000 patients in their initial cohort. They narrowed down the 2 groups, so they took out anybody that had non-complement mediated disease from the whole exome sequencing. So anybody that had DGKE, and all these random things that ended up presenting like atypical HUS, interestingly like col4A5, QN variants, which normally only have proteinuria, but they presented like atypical HUS enough that the team referred to Newcastle and they looked at it and they said, yes, it does look like atypical HUS, and then they had genetic testing. So there was really good, thorough phenotyping. So they mimicked atypical HUS, but when they did genetic testing, they took those ones out. And they only kept in 279 patients that were controls, so they were genotyped as well. And they kept 192 in the complement-mediated atypical HUS. So 192 in the treatment, 279 in the control. So what were their findings? So in terms of therapeutics, they found that eculizumab, doing the genetic testing quickly meant that they could only give the eculizumab to the complement-mediated group. So they saved money, and so they stopped it in anyone that it wasn't indicated as. Any collagen disorders, any DGKE or whatever, they withdrew it after the first 2 vials were used. In the end, after genetic testing, they ended up stopping it in 60% of the patients. That's pretty major, actually, because they were never going to, I suppose, need it. What was interesting to me was that all of these genes presented with atypical HUS, as opposed to Adam's Adam's 13, we know it can mimic it. But I didn't know myself that QVEN could ever mimic it. I didn't even know that PH1 could mimic atypical HUS. But these patients, they went back to the clinicians and they double-checked, and they did actually have a clinical diagnosis that fitted with the genotype after. But I thought it was really interesting, and they pointed out that it's really interesting to note that if your patient is not responding to the eculizumab, then they might have a diagnosis that's completely different, that you're missing completely. So DGKE, I think you all probably know that this is this encodes diacylglycerol kinase epsilon, and that's the gene, and it's found in the endothelium of platelets and podocytes, and it causes a non-complement mediated HUS. So it can look like HUS in 80%, it can look like MPGN, as you were saying, it can look like SRNS. And so for this, I know I'm quite averse to doing biopsy in general. I try and say do genomics and then avoid the biopsy. But in these ones, if you get this kind of nephropathy, A biopsy is really helpful to know where you're starting with. Also, they flip between these diagnoses, so they might have atypical HUS one time, but then they might develop SRNS later on in their lifetime as well. So they flip between these diagnoses, which is so interesting. They often have hypertension. The large proportion of them present under 1 year of life. So if you meet a family where there's atypical HUS under 1, they don't have much money, they can afford Sanger, then go for it and just go for this gene. And then the only other thing to mention here is that it's hopefully a relapsing course for the first 5 years of the child's life, maybe up to age 10, if they're unlucky. And then after that, they should recover, and so you can give the families a positive prognosis. So in terms of other prognostic information, this study showed that of the adults treated with, of the adults with the complement-mediated HUS, if they were treated with eculizumab, they had a better end-stage kidney disease-free survival than those with on the control. We know that anyway. The same thing was seen with children. So children here are, these are the control children, and these are the treated children, control adults, treated adults. So we know that if we find complement-mediated HUS, we can use eculizumab, and we can use that successfully. When they did the mutational analysis, I said CFH was the most common diagnosis, but they found that CFH, C3, and CF5 were the best responders to eculizumab. So you can see here the numbers here, so they had most significant response to eculizumab. Whereas CD46, they have non-significant response. They have good response either way, whether you give them eculizumab or not. And so if you have a family that have a CD46, then you don't have to necessarily, I mean, you could give them eculizumab, but it's going to give you marginal benefit. Surgical management, Satish covered already in terms of transplant. But I had in this UK cohort, they didn't talk about transplant or transplant recurrence. It's interesting, they talked about avoiding living-related transplantation. And then for family members, I was going to open the floor really to everybody else. It's quite a quick talk, but in my own practice, I've found that you can have children affected with atypical HUS, they're in end stage, and then you find the donor is one of the, they've inherited the variant from one of their parents. So we had one where there was a girl with end stage. Her father was already ready to donate his kidney to her, and then he was found to also have a CFH variant, but he was completely well, had not manifest at all. And there was a lot of emotional worry attached to that in terms of how are we going to do surveillance for this patient, for this gentleman, how are we going to monitor him, and then we had to have a discussion about the fact that he couldn't really be a donor. And they're very strict with atypical HUS donation if you have a genetic condition, and I wondered whether anybody else had also faced the same thing. And also the other thing was that I mentioned earlier on was that, remember I said that it's a sort of a risk in terms of developing atypical HUS. It's not that you will definitely develop it, but it's just such a worry for the families when they get diagnosed. In all the other conditions, I always feel very good about using genomics, but this, when it's things like this, you always end up having a mix of emotional, I suppose, baggage that you have to then manage. It's good to do anything like this with a trained genomic counsellor, I think. So in summary, it was quite a quick talk just to show how much genetic results can influence how you manage complement-induced atypical HUS, and you can do it really carefully and precisely. Be aware of the secondary causes mimicking atypical HUS. This is a pattern that we see across so many different kidney conditions. Don't always dismiss results that you get back, and ask the referring clinician to investigate for the condition. So if it's AGXT, ask them to look for PH1. And it looks like prognosis is influenced by genotype, although previous publications said there was no genotype-phenotype correlation. So I hope you all enjoy reading that paper. It's a really good one, and it's a nice cohort of patients a bit higher in number than our usual paediatric cohort. So thank you.